Welcome everyone to Swati Hillbridge. I'm Miss Ashwini, and I welcome you all to a knowledge sharing platform where clinical experience meets the real world practice. Through expert-led conversations and case-based discussions, we aim to bridge the gap between the science and everyday patient care. Today's session is part of our podcast series, bringing you practical insights, honest experiences, and meaningful dialogues from clinicians to who are shaped better for outcomes in their field. So let's begin. And I over to you, Miss Dr. Aashee. Thank you.
Good afternoon. Thank you, Ashwini. Um, I give a warm welcome to all of you who are attending our session today. I am Dr. Aashee Parganiha. I am a consultant urogynecologist and pelvic floor reconstructive surgeon from Nagpur. At the outset, I would like to acknowledge the stupendous work of Swati Spento's group for conducting these podcasts, particularly on a very important topic, interstitial cystitis and bladder pain syndrome. This disease has been eluding clinicians worldwide for decades with its heterogeneous patient profile, dearth of knowledge on its exact etiopathogenesis, confusing clinical pictures, lack of diagnostic procedures, and a consensus on treatment. Globally, ICBPS is being researched and studied in leaps and bounds. My interest in urogynecology stemmed from my post-graduation days. The surgeon inside me got thrilled with the intricacies of pelvic anatomy, and the clinician slash diagnostician in me gets tremendously rewarded when a puzzling diagnosis is clinched, long-suffering patients get satisfactory treatment, and among such mind-boggling conditions is interstitial cystitis bladder pain syndrome. And for our podcast today on holistic approach in ICBPS management with real life experiences, it gives me immense pleasure to invite and welcome our very respectable speaker, Dr. Meera Ragavan. Welcome, ma'am. Ma'am is a senior consultant
here. Aashee, thank you for the bridge.
Sorry, I interrupted, ma'am. Ma'am is a senior consultant urogynecologist and robotic surgeon at Apollo Hospital, Chennai. She is also a proctor and trainer at Hugo Ras Robotic Platform, convener of Tamil Nadu FOG certificate course in urogynecology, board certified lifestyle medicine physician, national board specialist committee member, treasurer of SOCI Tamil Nadu chapter, core committee of faculty of urogynecology committee FOXI since 2015. Scientific Chair of AICC RCOG 2025, an MRCOG trainer and examiner, Director of Ascot Apollo Simulation Center Coordinator for Obstetrics Skills. And she is also a winner of 32 gold medals in undergraduate curriculum and Best Outgoing PG Student PGIMR, Chandigarh. I would also like to congratulate ma'am on recently becoming the Empowered Relief Instructor certified by Stanford University, which adds another feather in her cap. Ma'am, would you please share about this recent achievement of yours?
Thank you. Thank you for the wonderful, kind introduction you've given. Thank you, Dr. Aashee. I was actually inspired by our FEPA society, which I'm a core member of. And for people to know, FEPA is under the umbrella of Swati Spento's as well, which is a female pelvic pain association. Which runs parallel to the GIPS, and majority of us are core members there as well, concentrating and focusing on understanding female pelvic pain better and making a difference for these patients. Empowered Relief is a program based on pain neuroscience, education, and for patient empowerment. Anesthesia and pain medicine, and it's an online certification which enables us to acquire the knowledge, the skills to be imparted to patients regarding pain neuroscience, to train the brain away from pain. We all know chronic pelvic pain is extremely challenging, not only for the patient, but also healthcare practitioners to empower them to deal with it. Medicines are not going to work, interventions are not going to work, but training the brain to walk away from the pain is something which is about pain neuroscience. And it's a certified course done by them where you have assessment of how you present as well. And I'm pleased to share that I'm the first one from India to get that certified by Stanford University. So I hope we can equip our patients better with this knowledge and awareness so they could feel better with regards to.
And we really congratulate you on this achievement, ma'am, and we are really honored to have you here. And that brings me to the first question. What entices you about ICBPS?
Pardon, I lost you there.
What entices you about ICBPS, or what is the thing about interstitial cystitis bladder pain syndrome, the subject that uh, encourages you or interests you to deal with the subject?
The magnitude of suffering which the patient undergoes and the inability or the difficulty in the patient themselves getting to find out what it is and vocalize to the healthcare practitioners. That still kind of bewilders me, because patient is suffering constantly, but they're not able to pinpoint what exactly is going wrong with them. They get treated in multiple ways. It takes a very astute clinician with a strong level of suspicion to pick this out and act promptly and in an appropriate time so that we do not have the effects of bladder pain syndrome. So basically what entices me is to carry out this mission and be the torchbearer of creating awareness on multiple platforms about the presence of this condition so that not only patients but healthcare practitioners also become aware and keep thinking about it and not just treating it as UTI or something which is in the patient's head.
To that point, I would really like to add one thing, ma'am. Something that you said. So many patients come to our clinic like they have a big bunch of paper, and practically they have been getting treatment of UTI. And very sadly, many a times, either they do not have any pustles, any signs of infection in urine routine. And many a times, it also saddens me to see in routine practice, if even pustles are present, culture is not done to treat UTI. So that's a separate topic. But yeah, many patients do come with getting prolonged treatment. And I also see when patients say, ma'am, when I was getting treated for UTI, I did definitely get relief for a small duration of time. And I have to explain to them that relief was not because of those antibiotics. Probably those were because of the alkalizers you were given along with the antibiotics. That was giving you a temporary relief. So
yeah. I totally agree, Dr. Aashee. There are two things to it. One, the alkalizers might get them better, and they think alkalizers are treatment for UTI as well and keep taking it. That's a wrong thing to do.
yes,
Another
yes,
one,
sorry.
that also is an aftermath of that. The second
Yeah.
point is they hydrate themselves temporarily better when they have a UTI because they're scared. The moment they have UTI, they think it'll affect kidney. They're scared. They hydrate better, which is never a problem, which is never a habit for them, and that also makes it better for bladder pain syndrome because we know that concentrated urine has more number of particles to irritate and sensitize the bladder. And we know from our own society, Dr. Sandor Lovas, that the hydration bladder diary reduces the bladder pain scores as opposed to a restricted hydration bladder diary. So,
very true.
So hydration and alkalizers temporarily gives relief, and which is why people think UTI treatment makes it better.
Yeah, and unfortunately, they keep on self-prescribing the antibiotics as well as the alkalizers, temporarily getting relief, and but still getting troubled again and again, again and again. And so it comes to us to differentiate it from a recurrent UTI and instead to come to a diagnosis.
Yeah.
So, ma'am, what is the prevalence of ICBPS in India, or would you say it is a rare entity as was once believed?
No, actually not. It is not a disease of the West. It is still quite common in India because of certain practices of having high spicy food or processed food. I see a lot of patients from the Northeast having this kind of a problem, and deep down in the South. It invariably is related to some food triggers and their habits and cultural practices. and worsens around the fasting times and things like that, probably because of a relative dehydration status which they might have. So it is definitely more predominant, but having said that, I might be biased in that I'm a urogynecologist and have referral practice, so I can't vouch for a much more common prevalence. But if they come with recurrent UTI, it is not just recurrent UTI. You need to keep bladder pain syndrome at the back of the mind after ruling out TB.
Ma'am, a couple of cases that I saw, they had been presenting with recurrent UTI, but actually they were a case of interstitial cystitis that led to voiding dysfunction and that led to recurrent UTI. So that was a trifecta, and it was a very difficult, ICBPS is already very difficult to diagnose, and it was a head scratcher for me. So,
No, it's true. It's true. Um, some of the younger patients who present to me have pelvic floor predominant kind of phenotypic presentation of bladder pain syndrome. So we need to sensitize our own fraternity, especially specialists, about the phenotypical classification of bladder pain syndrome, because we need to pick these out because they don't come like a designer package. Hey, I'm bladder pain syndrome. It's never going to be that. They have
sure.
different phenotypical presentations, and profiling of these patients is crucial to pick out these phenotypes so we can direct the treatment according to it. It's not one size fits all in bladder pain syndrome. That is the beauty of this whole conundrum.
True.
It's a real brain challenger, and it involves a lot of listening to the patient, building a rapport with the patient, getting to really feel from patient perspective. So it's very crucial to get to understand what they're telling us. Most of the time, it's the non-verbal clues which help us pick out these phenotypical lesions. They're constantly in pain. They do not engage well in conversation. They could be depressed. They'll be sitting at the edge of the chair. They'll be fidgety because they're not able to sit comfortably. They might come with low backache, fibromyalgia, allergic tendencies, predominantly bowel symptoms sometimes, especially obstructive defecation types or irritable bowel. So we need to really keep our antenna up so that we can pick out these nonverbal clues. And it feels like Sherlock Holmes sometimes, and that's
Oh,
probably
yes.
what is quite intriguing and enticing
Uh,
about bladder pain.
Certainly agree with you, ma'am. And on that point, could you please elaborate the U-point phenotyping, uh, and do you use it? Because I feel many points, like if a patient presents, as you rightly said, no single phenotypic presentation is like one key fits all presentation is there. Many patients may have different types of phenotypic presentation, more than one. So could you please elaborate on U-point phenotyping?
Yeah, the U-points bladder pain syndrome phenotyping is to kind of channelize as to what is the predominant presenting or a conglomeration of the presenting symptoms. So it could be related to urinary or pelvic floor or inflammatory, neurological, allergic kind of thing, as well as the somatic one as well. So the usual presentations of the bladder pain syndrome. And that is what is quite intriguing because we have to direct our treatment according to it as well.
Yeah, and I guess we have to, as you rightly said, we have to consider various points of the U-point phenotyping because many times patients have different multiple phenotypic presentation. They could have psychosomatic, psychological, neurological, as well as bladder centric. So yes, we definitely wear the cap of Sherlock Holmes when we treat ICBPS, I guess. So, ma'am, can we discuss about the clinical presentation of these patients? Ma'am, am I audible?
No, you're not. Can you hear
Ma'am,
me?
yes, you're audible, ma'am.
Yeah.
I said like
I
yes,
agree.
definitely we wear the cap of Sherlock Holmes when we deal with
Yes.
interstitial cystitis. So shall we discuss about the clinical presentation of these patients?
Yes. Yes. Basically, when the U-point system is used or otherwise also, we need to look into the urinary symptoms of the patient. The triad of bladder pain syndrome classically with its pain, urgency, and frequency, what we call the puff triad, is very crucial in clinching the urinary type presentation of bladder pain syndrome. This itself can lead on to the next one, which is the P, which is the psychosocial dysfunction with depression, anxiety, as well as psychoaffective disorders like stress. The third thing would be organ specific, like finding specific issues within the bladder. Like we find lesions in the bladder pertaining to whether it's a Hunner's or a non-Hunner's type of presentation of bladder pain syndrome or interstitial cystitis, or they can be urethral pain, and patient might have clitoral pain as the predominant presenting one. Fourth is infection. The infection might be leading or contributing to flares and perpetuating the symptoms of bladder pain syndrome. Neurological dysfunction in the form of fibromyalgia or severe pelvic floor spasm, myofascial bands, and tethering, and these kind of problems leading on to dyspareunia, obstructed defecation, voiding dysfunction. And finally, the sexual dysfunction. We invariably kind of brush it on the carpet. This is a very important thing as part of the domain of pelvic floor we need to concentrate on, because majority of them will surface in a fertility clinic, because we do not know whether sexual dysfunction begets fertility, fertility begets sexual dysfunction and anxiety.
Sure.
But this
That's
is
another
one of
conundrum.
the crucial steps. We all are guilty of not spending enough time in a sensitive manner. And this time and again clinches the clue behind the voiding dysfunction, behind the pelvic floor spasm, because the sexual dysfunction could be a trauma response to past sexual abuse, past childhood abuse, and so on and so forth. And the myofascial bands can be persistent because of that. So on this platform, thank you for asking this question. But through this platform, I would urge all practitioners to spend some time sensitively and discreetly homing in on this domain of pelvic floor, which is the least attended to, but it is far more prevalent than we can ever imagine.
I so strongly agree with this point of yours, ma'am. I so strongly agree because I've always seen that spending few extra minutes and giving notice to certain particular points, certain pointers. Some could be leading questions, some could be from the demeanor of the patient, from the way they are explaining their problem or the way they are presenting themselves. Just a little bit of detail into the details of attention, and it gets a bit easier for us to get closer to the diagnosis clinically
Absolutely,
per se.
absolutely, absolutely. Imagine patient telling you, newly married couple not able to consummate marriage because they're not sure whether they have a penetrated intercourse and has severe pain, and the patient walks with difficulty. Always examine closely. There will be friction-related tears or fish ring or graces around the perineum at the posterior fossa. And if you can see how the patient lies on the couch, the patient will be having her hips slightly up with a tented up pelvic floor. So that itself clearly shows why penetrative intercourse has not happened properly or has caused pain, because the pelvic floor muscle is tight, pulling the perineal body up. So the vaginal hymen or hiatus is not allowing the pelvic floor to come down. So they hit the perineal body, and that's why the penetrative intercourse has not happened. But women often come to the clinic saying, do I have a narrow vagina? It's not a narrow vagina. It's the pelvic floor acting like a trap door, functionally making the vagina narrow. So
Yes.
do not immediately go and do a hymenoplasty or a fentons to increase the vaginal capacity. It's about teaching the patient how to relax her pelvic floor. It's very, very, very important.
And it really goes a long way when we include the husband or the sexual partner into
Yes.
the discussion. And I have found it quite easy when I explain to them like they can do Thiel's massage, and I teach Thiel's massage to the partner. So I always say that it will always build up some intimacy too. So besides taking care of your sexual problem, the penetrative problem.
And more than that, it is socially and culturally quite rewarding and reassuring for the couple to know that there is no anatomical problem there. And it is only a matter of understanding pelvic floor and relaxation of the pelvic floor for both families and the individuals alike. Because socio-culturally, India is still a country bound by these norms, and patients are put into unimaginable pressure from the family setup.
True, and patient is always happy to not go under the knife if we can
Very true.
manage
And this
medically.
is not an indication for the knife anyway.
Yes,
So
sure, sure. Ma'am, so considering the clinical presentation, is there any particular duration of presentation like we should consider, or what should be the duration of these symptoms
by
to?
the time they come to us, I think it's months. So I
Yes,
would keep it as a minimum of 6 weeks to 3 months. I don't think anybody should. Pain is inevitable, but suffering is optional. We should abate the suffering as much as we can, because body uses pain as a protective mechanism. So
yeah,
something is not right, which is why pain is persisting. When it
very true.
becomes chronic pain, it completely unleashes a different kind of animal. It's no more domesticated from that point of view. So before it
Absolutely.
becomes chronic pain, I think we need to intervene.
Agree. Ma'am, have you come across any young children with ICBPS?
The youngest I've come across is somebody around 16. I haven't seen anybody less than 16.
Okay. If you permit, I would like to share. I recently came across two little girls. One was 12 years old and one was 9 years old. The 12-year-old, she came from outside of Nagpur. So the parents were not very willing to come for a regular treatment and everything. So I lost her to follow up. But her diagnosis was absolutely pointing towards ICBPS. Unfortunately, I lost her to diagnosis to follow up. And the second one is a 9-year-old girl. She had been getting treated for GI symptoms, like she used to complain pain abdomen, not able to pass stool and urine. So she had been going to gastroenterologists, getting laxatives and painkillers. But somehow I was fortunate that she came to, I would say I was fortunate because I was able to help her because the disease getting diagnosed at such a young age. I felt like she
Yeah,
had a long way to go, and
agree.
long way and long life to live with this disease. So fortunately, we were able to catch it at a very young age so that she can modify her lifestyle according to the disease. So youngest
Absolutely.
that I came across
So,
was nine
yeah,
years.
possible. When the time I'd seen her, she was 15, 16, but she must have had these symptoms for 2, 3 years, so it would be 12. So,
Yes.
yeah, yeah.
Yes. But ma'am, as we know, ICBPS mostly gets misunderstood, misdiagnosed. So is there any diagnostic test available for it?
In the sense, it's a clinical scoring which we use. We know
Yeah.
Dr. Taneja's Apollo clinical score or the Olia Resant or the PUF. It's a diagnosis by exclusion. But if we do a cystoscopy and find a Hunner's lesion, it is pathognomonic of bladder pain syndrome and ICBPS. But having said that, we not finding a Hunner's does not still rule out, and not finding any bladder centric disease still does not rule out bladder pain syndrome.
Very true.
That is what I would like to emphasize here. What walks like a duck, quacks like a duck has to be duck, but sometimes you have the goose coming in as well. But you need to find
I
that
really
out.
love that phrase that you've used, and I'm certainly going to use that in my clinic. I really love that phrase that you said. Ma'am, with this background, I believe we will further this discussion with the case-based discussion of real-life case scenarios. So, I would like to request you to start the case presentation.
Sure. Today, I'm going to, because most of us here already understand bladder pain syndrome, we need to move further from understanding, awareness, diagnosis. I'm going to play a few things about real life scenarios which involve intravesical installation, how we could manage these patients when they present differently, how useful it is as an intervention which can be done in your clinic itself. So the whole thing is homing in on understanding the phenotypes and how review what the evidence is actually there about intravesical therapy and case-based learning and outcome expectation as well. We all know that Hunner's, non-Hunner's, and myofascial predominant and neurogenic inflammatory broadly classifies the various phenotypes associated with bladder pain syndrome. The crucial thing is go in a stepwise fashion, but run them parallelly. Don't do it. I'll rule out infection, come back in 2 weeks. I will do this, then come back in 2 weeks. By the time you miss the boat. So rule out infection, take a symptom score. Patient can fill this very quickly. Do your O'Leary-Sant or your Apollo's clinic score. If they tick it and a high score comes, they often are in bladder pain syndrome category. Identify the phenotype. Crucial is to appreciate the sexual dysfunction as the pelvic floor dysfunction which comes along with it. Attack the pain in a multimodal way. So the patient might present with musculoskeletal symptoms, might present with sexual dysfunction, might be having pelvic floor dysfunction and bladder-centric problems. So treat the frequency urgency, address the pain, teach them pelvic floor relaxation, address the sexual dysfunction. So you cannot do it all. So you need a multidisciplinary team and a multimodal prong approach for treatment concurrently, which happens. So the patient starts to get feeling better. Most often they come back and say, your tablet did make me feel better with the urgency and frequency, but this pain is unbearable. That means you've not actually instituted measures to correct that pain or the sensitization of nociception, which comes along with it. So where does installation actually fit in? Because we know the oral agent has a bioavailability of only 6% and 94% is excreted off in the feces, it doesn't quite touch the bladder lesion if it is there to desensitize or replenish the glycosaminoglycan. It is like the, again, to explain to patients, I tell them, it's like the non-stick cookware where you have the Teflon lining. To replenish that lining, the bladder needs something like a coating. And for your oral agent to recreate that and for you to not trigger off things which break that lining. So if I'm going to keep doing deep fry in that, it will get charred and it'll keep sticking. So I need to recreate something beforehand so that it is crucial for us to understand how to recreate an intravesical installation. Superbly helps the replenishment of the gag layer. And it's like a bridge therapy to downregulate somebody from having an acute flare to go on to a maintenance therapy, and works beautifully when you actually understand the phenotypic presentations. So we do have a lot of intravesical therapy where the gag layer by hyaluronic acid and the installation with pentosan polysulfate. DMSO had been used because of the bladder fibrosis we are not using. We do a cocktail based on Parsons cocktail, which is the lidocaine, heparin, and the bicarb, because heparin being another glycosaminoglycan type which can replenish that layer. It is very good. Evidence summary noticed that the hyaluronic acid combination improves symptoms in about 40 to 70%. So do not pitch your conversation or your counseling saying, I'll cure you. This is, again, to draw an analogy. I tell patients, this is like asthma, where you will have flares and good days and bad days. It's seasonal variation. If you're stressed, you're not sleeping well, your diet changes, you will have flare-ups. So do not expect an asthma patient to have ice cream and not feel, not get an attack. An ice cream can precipitate an attack. Refrigerated drinks
I really love your analogies, ma'am.
Yeah, you will have flares. So do not promise them a permanent cure. Do tell them most of your symptoms will be under the lid. But if you have triggers, they will flare up, and it's our duty to handhold you during your triggers so you don't have them quite often in the year. That is, should be the counseling pitching for our patients because it is more realistic and achievable. And the Parsons intravesical installation, which is a combination of heparin as well as lidocaine and bicarb, because it has an anesthetic agent in it. It has the chondroitin, which is going to glycosaminoglycan, which is going to soothe the surface, as well as the alkalizing agent. It is going to offer excellent symptom relief when there are acute flares. So case one is a 35-year-old teacher with a 2-year pelvic pain, frequency about 18 per day. Note the number of times she's going to the washroom. This is so disrupting when you're a teacher. So you need to understand the social impact she's going to have on our daily routine and quality of life, and a very high score on the puff triad. So it improves after voiding. So bladder filling is a problem. Bladder should not pain when it's filling. It's like a balloon which distends when the water is being filled without bursting. When it doesn't do that, that is when bladder pain syndrome sets in. So that's why she complains that she has pain during filling and feels relieved after voiding. But it's not UTI, and the ultrasound is normal. You catch her at this stage, give her good relief, she will not have a high residual urine. High residual urine already starts showing voiding dysfunction because of pelvic floor dysfunction. So we should not allow that to happen. This is a non-Hunner's bladder pain syndrome. We recommended hyaluronic acid, which is not available. I use a combination therapy, decrease pain, decrease frequency, and better improvement in quality of life scores. Another 48-year-old with severe suprapubic pain, Hunner's lesion, failed oral management. It's not uncommon to see that they're not getting better even after 3 to 6 months of oral therapy. Again, tell the patient it's a long drawn process, and oral treatment takes good 3 to 6 months to get better because of the nature of that bioavailability. It is not like fever where you take paracetamol and next day it disappears. Do not expect that. Pitch that very right so you don't get disappointed clients. So make sure they take it regularly for 3 months, and it's a 3-time dose every 8 hours. Store it in the fridge door, because if they store it outside, it gets degraded, and already with poor bioavailability, it's further not effective. So we do ablation of fulguration. I do invariably fulguration, and it definitely improves after I put in an intravesical installation. So pelvic floor rehab. Sorry, are you able to see?
Sorry, I would like to interrupt, ma'am. I had one personal question for you. I had a couple of patients who had the Hunner's lesion near the ureteric opening. So I was skeptical, and I was not able to do the fulguration, fearing I might damage the ureteric opening and do a damage rather than any good. So I had to
then
come
would
out
inject,
and
or take your help of your urology colleague, or inject triamcinolone in the base of the lesion. That intralesional base of the lesion in introduction of the steroids also is a good way to deal with Hunner's lesion at that point. If you think it's too extensive, or you're worried about damaging crucial structures, and if your urology friend is not just next door, just do the triamcinolone injection. That is a good way to deal with the Hunner's lesion.
ma'am, could you please elaborate the triamcinolone injection dosage and the points?
I generally use the 1 vial of Kinalog or Kinacort injection, and also inject it along with minimal lignocaine around the Hunner's lesion, and take an opportunity to do an intravesical installation either in the recovery or the next day.
For these patients,
Cystoscopic injection.
Yes, as I was not able to do fulguration, so I resorted to the pelvic floor relaxation therapies, painkillers, and intravesical cocktail installations. But fortunately, they are along with dietary modifications. So fortunately, they have been responding.
Yeah. If they do not respond, go back, because Hunners, if they don't respond, they definitely will respond to fulguration or intralesional therapy. So that is very, very important. Beyond its installation, we need to, like Dr. Aashee now clearly said, pelvic floor rehab. I do not write pelvic floor training. nowadays, because everybody, even the physiotherapists, if you don't clearly mention, they do only pelvic floor Kegels. Kegels is actually not to be done in patients with bladder pain syndrome, especially with the, and we talked about updated therapies beyond installation. Pelvic floor is not equivalent to Kegels. Kegels are not to be done by patients with bladder pain syndrome and a pelvic floor predominant phenotype, because it worsens the symptoms, because already a tense pelvic floor will be further tightened. So it is pelvic floor relaxation, which is why I specifically write pelvic floor rehab. So it is very, very important to rehabilitate the pelvic floor, what it has been habituated to, into a new form of tone. So that is why I use that terminology. Neuromodulation definitely helps in certain subset of patients with bladder pain syndrome, especially associated with unabatable urgency frequency, or in patients with severe voiding dysfunction, because it neuroregulates or neuromodulates the system itself and helps in certain patients. Oral therapy has to be continued, mainly from the pain perspective. Amitriptyline is a very good method to tackle this pain associated. Next comes the pain neuroscience education, which I talked about, with empowered relief or mindfulness-based reduction of the pain as well. So these are skills which not only the patients have to equip themselves, I think practitioners also, to be able to guide them to the appropriate skill set which they can practice, so they feel empowered that they are part of the treatment. Otherwise, coming to a doctor every time, waiting in the clinic with this kind of problem, I'm sure all of you see patients from abroad as well. This is the situation in India, whereas in the Western countries, they need to wait 6 months to see a specialist. And here we are having specialist awareness very less. Imagine the Western countries where people clearly don't understand or appreciate what the patient is telling about, and it takes months for a patient to even get an online consultation. So, which is why we need these patient pain neuroscience education, so they feel empowered on what they can do till the time they get to see a specialist to get better. So these are inevitable skill set which patient has to acquire over time, especially if they're dealing with chronic pain, because it's quite debilitating, and time off work and lack of productivity further worsens their access monetarily to expensive therapies. So we need to be quite sensitive about these as well. Botox definitely helps in certain select cases, especially with the predominant urgency frequency pattern. And one caveat here is, this is one of the conditions where I inject botulinum toxin in the trigone area to reduce the sensitization of the nerve endings. The normal teaching is spare the trigone when you do the Botox, but here the Botox has to be targeted specifically in the trigone, because there's plethora of nerve endings and the main sensory urgencies because of that, and bladder pain syndrome is one indication where I will definitely inject Botox into the trigone as well. And we also know when there is a pelvic floor spasm, we inject Botox into the fan of levator on both sides, because it reduces the pelvic floor tone, and the defecation or the voiding dysfunction also gets better. So we can do it in the bladder, do it in the trigone, do it in the sphincter, do it in the pelvic floor when actually considering a patient with severe bladder pain syndrome. The third case is a 32-year-old postpartum woman. This is one place where intravesical installation really, really helps. In patients with post-renal failure, renal dialysis, renal transplant, we're not sure of the oral PPS, the bioavailability, or patients with severe vomiting or gastrointestinal problem, pregnancy and postpartum, and they're breastfeeding, intravesical installation is truly a boon and a quick fix. A 32-year-old postpartum woman, severe flare, negative culture. We use the combination of heparin because heparin is safe, lignocaine because it's short-acting, and alkalizing agent like a soda bicarb. Rapid reduction in pain and urgency. Imagine a young mom who doesn't have good sleep, already stressed, has to breastfeed, is not able to sit, and has severe pain and urgency and frequency. That's a doom cocktail for her life, and quickly she can go into postpartum depression. So the minimum we can do for this patient is be sensitive about the impact it has and quickly abate the symptoms, and helpfully intravesical installation comes in quite handy. So sterile catheter technique, usually retain the cocktail in the bladder for about half an hour, avoid over distension. The usual volume comes to about 40 to 50 mils, not more than that. Combine invariably with pelvic floor rehab and assess your patient's betterment, because it objectively makes the patient feel better. Look at her scores before, look at her scores after. She herself feels very motivated and says, yeah, I am getting better, and it's not all as bad as what I imagined it to be. Expected outcome, improvement within 4 to 6 installation. Gag restoration, like your RBC, like your semen count, it is 120 days and it will get better within the 3 months. So don't worry about it. Give it time. And the QOL improves steadily. So take-home messages: phenotype directed image therapy is essential. Installation works best in multimodal care, and we can use the cocktail for that and combine with the pelvic floor rehab and pain reprogramming. I've used these guidelines, but I would also like to quickly emphasize on our pentosan polysulfate installation, which has come, and I've used quite a lot of patients by now. I'll be probably presenting the entire series in the next GIBS. It is quite rewarding, quite encouraging to use that installation with comparison of the pre and the post installation. I follow a protocol. If the patient is a localite, I use it weekly for the first 6 installation and then go on a maintenance therapy. If they're not able to come, it'll be 2 weekly, like every fortnight, and then go on to a monthly maintenance. So 6 installations in the acute phase, and then once a month for the next 4 installation. That tends to really improve the quality of life as well as reduction in the symptom score related to bladder pain syndrome. And if patient has not done very well with the oral therapy, or already had in the past conventional intravesical installation and not got better, or the severity of the score is quite high, or in challenging patients who are post-renal transplant or even who have had a long-standing bladder pain syndrome, I tend to go for BPS installation at the first itself rather than as a second line. So this is my practical experience as far as the pentosan installation is concerned. That completes my presentation. Thank you.
Yeah. Many a times, clinically, patients do ask, like, what would be the duration of this treatment, or what will happen if the symptoms recur? And when we do explain about the gag layer and its replenishment with the treatment, they are also concerned that what if the gag layer gets disrupted again? So what should we explain to them? What should be the duration of is there any guideline or evidence-based results, like what is the duration of this treatment of replenishment of gag layer, or once we are treated, we can expect a long-term benefit? Because many patients do come with flares, and many patients do come with recurrence of symptoms.
A very good question. I am not aware of duration of replenishment of gag layer. The science behind it usually says it's 3 months because it's a regeneration which happens at that point. So do expect symptom relief by 3 to 6 months. But a UTI or a stress factor or a dietary trigger or a lack of sleep are the usual triggers for a flare-up, and identify those triggers and handhold them to reduce the suffering or worsening of the symptom score during the flare, which is why frequent installation at that time can happen, and that can make the patient better. But they need to be on treatment till as long as they get better with it. So it's not a short fix. They might need to be with us at least for 6 months. And I've seen patients going from grade 4 interstitial cystitis with a really bad bladder coming on to grade 1 or lesser than that, or no lesion inside the bladder with these therapies. I will give you an example of a patient who used to come and cry and said her husband was a biker and they both go on bikes for a long travel. which she was finding it very hard with her bladder pain syndrome because the frequency was 30. Nobody understood what she was going. Cystoscopy revealed grade 4, and subsequently she had intravesical installation, dietary and pelvic floor rehab and everything. Now she has a clean bladder. Her way of looking how her life has become better, she has traveled with her husband on the bike to Leh Ladakh, and that is mission accomplished for her. That is cure of her bladder pain syndrome.
I can so absolutely share the emotion that I can see on your face when you describe that particular achievement. Because definitely when patients have been suffering for so long, it really gives a sense of achievement.
They feel they're not normal anymore. They have
Yeah.
lost some part of their life to this disease. This is now controlling not only their body, but also their life. So if you empathize with that fact, that is where you need to bring the patient, you need to handhold them to that journey.
Yeah, when I write treatment to the patients, the oral treatment besides the intravesical, in my under the RX, I always write pelvic floor rehabilitation, maybe oral comfora. Then my last point is meditation. That I give them as a
Yes.
treatment. You have to do meditation. You have to do relaxation exercises, whether pelvic floor or mental relaxation. So my
Absolutely.
go-to sentence is you give all your tension to your husband, so you just don't have to take any stress. So at least one arena you have to take care of yourself.
True. Absolutely, Dr. Aashee. Agreed.
Ma'am, could you just elaborate any particular intravesical regimen that is your favorite, which you have the best
I,
experience with?
I do two of them. One is the cocktail which I use heparin 25,000 units along with soda bicarb, along with lignocaine full vial. In patients who have severe pain, I use bupivacaine, but I make sure I keep the patient a bit longer so as to make sure they're voided and not going into retention. I usually combine this with a steroid, which is like hydrocortisone. So it basically reduces the inflammation. I use it judicially, the steroid, because if there is the flare where there is an infection type phenotype, I don't use the steroid. I use
Ma'am,
gentamicin
on
installation
that note,
instead.
can I ask a personal question? Because in couple of cases when I used steroid, the patient in the couple of hours after the installation, they reported increase in the symptom, and
Yes.
for a couple of hours they were not able to void. Their symptom
Yes.
was increased. I had to give them some relaxants and painkillers, and
I don't know.
over a period of
It gets better, but the steroids have to be used judicially. So that is why phenotype is important. It's not one
yes.
size fits all. If infection predominant phenotype, I would avoid the steroids and use a gentamicin, because we know intravesical installations are now the in therapy for recurrent UTI also, because recurrent UTI also denudes the gag layer. So that is very important for us to appreciate the importance of intravesical. Intravesical, we do not need to look at like a a blinkered way that it is only for bladder pain. It is good for radiation cystitis. It's good for hemorrhagic cystitis. It's good for recurrent UTI, because the aim is to replenish the gag layer. So whatever it takes to do it, do it. So judicious use of that. But now I use a cocktail where I put in lignocaine first, wait for about a minute, then put a alkalizer like a soda bicarb, and then do the pentosan installation, because pentosan installation can be quite painful at the time of the installation. It's like a burning sensation. First two installation patients do complain of that, and then they get better. But to avoid that, I use a local anesthetic and an alkalizer, and then do the installation 30 ml and wait with them 40 minutes, and then they get better.
The dwell time is 30 to 40 minutes.
40 minutes. But miraculously, within the second or third installation, the way they dress up itself changes. They come in pastel colors. They're more, glamorous looking nowadays.
Very true, very
They're
true.
very, very happy.
Very true.
They're chirpy. They're chatty. Previously, they would look at you as, oh my God, I have to come to yet another doctor who will tell me this is how it is going to be. But now there is something to look forward to.
So true, clinical presentation. So
Yeah.
true. You
Yeah, this
truly
is
painted a
about
very true picture, ma'am.
yeah, this is about again, yet you can develop your Sherlock Holmes looking at all these non-verbal clues in there.
Yes. So, ma'am, I think I would like to, on this note, we should invite questions from the audience.
Yeah.
And do we have
thank you,
any?
Dr. Aashee. You've shared it pretty much. We are on the same page, and it's beautiful talking to a person with a similar mindset, with a similar focus, and
I
similar
cannot
goals.
I
It's
cannot share
beautiful, this conversation.
how much I'm loving talking with you, and the proof is that we were so engrossed in this
I know we didn't
discussion
even
that
realize the
we
PowerPoint.
didn't realize about the PowerPoint.
No,
So
it's been a
it's
wonderful conversation, and it
true,
didn't
true, true,
feel
ma'am.
like it's a webinar or a podcast. It's such a beautiful conversation, and thank you for
At the
enabling it.
at the back of my mind during our discussion, multiple times it came to my mind like I'll definitely meet ma'am and I'll go to Chennai. One visit is definitely due, and we'll sit and have a cup of coffee and discuss
100%,
these things.
definitely.
It
You
will
should
be a
do a
real
live program as well
yes,
in
yes,
person.
certainly, I would love to. So, Ashwini, do we have any questions from audiences?
Not yet, ma'am, not yet.
Thank you, Ashwini, for enabling this, and thank you, Swati Health Bridge. This
Yes,
is
ma'am.
quite enjoyable, actually.
Great to know you have enjoyed, ma'am. Great to know.
Absolutely.
Yeah. So if there are no more questions, Dr. Ashi, if you have any questions, you can ask Dr. Meera.
Actually, I believe I have almost covered all the queries that I had.
Perfect. Perfect. So shall we call it a day?
Yeah.
Yeah.
Perfect. So
Yes,
I'll end this. Yeah, yeah, ma'am. Yeah, ma'am.
actually, I was just gonna say, as I say to my young one, like whenever I want to make him excited about learning something, I tell him whenever we learn new things, our brain grows and glows. Our brain starts glowing. So he's just 5 years old, so he's very impressionable. So he gets very excited. Mom, my brain is glowing. So right now, I believe the audiences and me, we are having a glowing brain. So it was a really wonderful experience.
That's wonderful. And so is
Perfect.
mine. I've really enjoyed the presence and the conversation. I'm sure it makes a huge difference for all of us here to understand and appreciate what exactly this whole thing is about. And the more we talk about it, the more awareness we create, we'll have less and less suffering amongst our patients, and they would have better quality of life. At the end of the day, it's a patient-centered approach we need to employ here, and that is what we are here to achieve.
Yes.
Agree, ma'am. Okay, and this brings us to the end of the today's episode of Swati Health Bridge. We sincerely thank you, Dr. Meera and Dr. Aashee, who is consultant in Uro-Gynaecology, Obstetrics, and Gynecology, pelvic floor reconstruction, vaginal and laparoscopic surgery, from Nagpur, Maharashtra, for co-hosting and steering today's discussion so thoughtfully. Thank you to everyone who have tuned in, and we hope we connect with you again in our upcoming sessions. Thank you from my side, and thank you all.
I would
Thank
really
you.
love to thank Meera ma'am for giving her time. She was very busy and she was traveling, but still she gave time and her wonderful insights into the topic. And I'm sure everybody enjoyed and got enlightened and got a glowing brain. So on that note, I would really thank you, Ashwini, for and Swati Spentos for organizing
Yes.
this podcast.
Yeah, I would specifically would like to thank Dr. Taneja, Dr. Pandey, and our Dr. Or Vishal Jajodia for enabling this kind of platform for worldwide awareness about this condition, which is brushed under the carpet most of the time, but now pretty much has come to the forefront, and many people are now aware. So, flag bearers for this mission. Thank you very much.
Yeah, I second your sentence, ma'am. Definitely. Big thanks to Dr. Taneja sir and Dr. Pandey sir, who
Yeah,
are the flag bearers of this topic in our country.
thank you.
So shall we conclude, Ashwini?
Yeah,
Okay.
Yes,
thank
ma'am.
you.
Yes, ma'am. Thank you all. Thank you. Thank
Thank
you
you,
all.
ma'am.
Thank you.